Thank you.
There.
Thank you, Mr. Chairman. I'm happy to present our work on the cementless revision system that we use to treat pelvic defects. And as you already heard by Professor Bakci, we classify our defects according to the same D'Antonio system. There are a lot of systems on the road, but I think there's none of them is really reliable. The most striking difference is the one between the segmental defects and the combined defects and this type 4 pelvic discontinuity. And I'll show you that we are able to treat all these defects with one kind of implant. Now, if you look at this picture of this radiograph, it's sort of difficult to say what kind of defect we really have. So in these cases, we sometimes use a CT scan, and there you can see that you still have a dorsal column, and that you probably, it's a sort of straightforward procedure that you can use. In this case, it's more difficult. You cannot say, is it pelvic discontinuity or not? So you have to be prepared. And there are certain possible treatments here. Usually, we would use the reinforcement rings like the Schneider-Burch ring or the Müller or Ganz rings, or we can use a jumbo cup, we can use custom-made implants, or as we've heard already, the impaction bone grafting. Now, the concept of our implant that we use is an oval-shaped cranial elongated cup with a distal alignment of rotation center because of the oval shape of this implant, and it has a 3D macroporous structure which gives us a very good ingrowth, as you might imagine if you look at this picture here, and which gives us a cementless fixation. It comes with or without a flap like this one. It's an anatomical flap, and with or without a peg, and I'll show you why. Now, here's a more artistic drawing of the different defects, and if we only have a volumetric defect, which has to be filled like an oval-shaped defect, we can use the simple oval-shaped cranial cup. If the defect is more structural and we lose like the acetabulum here, it's a perfect indication for a cranial cup with a flap, because the flap secures the position of the cup to the iliac crest here over there. Now, one of the problems that we have to deal with is the pelvic discontinuity, and in this case we use the cranial cup with a flap and a peg. So the mechanism is like a clamp that's clamping to the iliac crest, and we don't have to rely on a fixation of the ilium to the rest of the pelvis. And I don't want to talk about this one. Now here's an example of a 70-year-old patient, after a prostate cancer and radiotherapy. He had very soft bone there, and he was treated with a Müller type of reinforcement ring in the first place, so the bone was very soft, and as you can see, it didn't work. So the next step was taken, and they used a Schneider-Burch ring, which is problematic in this case also, and it migrated into the pelvis, which was very difficult to remove afterwards. And one of the way to treat it is with a cranial cup. This is an old version with a peg and a flap there. Now, let me show you again the principle, how it works. It's in a pelvic discontinuity. This cup is fixed in the dorsal part of the ilium. And this clamping mechanism relies on an intramedullary fixation by the peg combined with this flap on the outer side. And if we go back to anatomy, we can appreciate why we do this. Because if you regard the pelvis as a framework, you can see that the best parts that you can use are where the force is transferred usually. It's the dorsal part of the ilium. The others are not as good, and by the previous implant, usually the acetabulum and the anterior and posterior wall can be destroyed completely. So we evaluated 50 consecutive patients that we did with mostly oval-shaped or combined defects, and we followed them for five years in the mean, and the mean age was 65 years, and you can see that the Harris-Hip score improved moderately, and there's a significant difference between the type 2 and type 3 defects and the type 4 defect, obviously. So most of the patients had a revision, a first-time revision, 3 a two-time, 3 a second time, and 3 a four-time revision when they came to us. So we had 39 aseptic cases and 11 septic, which we treated with a two-stage procedure, and we could create or reconstruct the center of rotation according to a method that we used from Ranawat in 92% of our cases, and 90% of the patients were satisfied. That means that 10 weren't satisfied and wouldn't let the procedure be done again. So here you can see a type 4 Antonio defect with a pelvic discontinuity, which was treated by this oblong cup with an intramedullary fixation in the dorsal part of the ilium combined with this flap, and that gives you a very stable fixation. Now, the complications that we had were the general and early were pretty normal, I think. Late complications, we had 4 aseptic loosenings, which ended up 2 times in upsizing of the cup size and 2 times in an additional use of a flap. And these only happened in the type 2 and type 3 D'Antonio defects. The survival rate after 5 years was 92%, which I think is very good. And if the endpoint is cup revision, if the endpoint is any sort of revision, then it's 84% because we had 2 dislocations also, and the liner had to be changed. Now, our final aims of the revision, and you already heard that by Dr. Bakshi, is a stability that we reach, and in our case, we can rely on a primary stability, which is, in my eyes, in my view, it's the most important thing that we can have to establish. It's a reconstruction of the center of rotation, and in this case, it's a secondary stability by bony ingrowth because of the macroporous structure that we use. And we don't really get a good recreation of bone stock unless we don't pack the spaces behind the cup. We could do that, but usually we don't. We don't use too much bone. So let me thank you with this picture of Würzburg, and thank you for your attention.
Okay, thank you very much for a nice presentation. Do we have any questions from the audience? I also think that you had quite good results. We all know that these are very difficult cases to solve, but it remains naturally to see what happens in the longer follow-up, because that's critical.
Yeah.
Yes.
I agree.
Hi, I'm Dr. Fatih from Istanbul. What do you do about weight bearing? When do you allow to full weight bearing or partial weight bearing?
You know, it depends on the intraoperative findings that we see. If we get a really primary stable fixation, we can let them immediately weight bear. But usually we would stick to these 12 weeks if it's a pelvic discontinuity and we have to rely on at least some kind of ingrowth. So it depends.
I'm Yusu Park from South Korea. Very good concept of clamping mechanism for very difficult pelvic discontinuity. And my question is, What about fracture healing at the discontinuity? And secondly, the inferior distal part of ilium can be a bone ingrown attached to the distal part of the cup after the clamping cup.
To answer the second question first, you cannot connect the distal parts to the cup. It's not made for that. And to answer the first question, second, since we do a lot of tumor surgery also and a lot of pelvic reconstruction and pelvic resections, we know that you don't have to recreate this the upper parts and the lower parts together. So you can leave the ilium as it is. There doesn't have to be a connection. Even, we did a lot of custom-made cups where we fixed the upper part to the lower parts, to the pubic and to the other bones. So we saw that this gives a lot of stress to the implant and leads to an early loosening. We don't do it at all anymore.
Okay, thank you. We thank you for the presentation.